Hey everyone, this is Katie Buss. I want to quickly talk about Chapter 21 and the NSCA's Essentials of Personal Training. This is going to be orthopedic concerns, injuries, or rehabilitation concerns. First thing, I just wanted to quickly make sure you know what a macro trauma versus a micro trauma is. Usually a macro trauma refers to something that happens suddenly. It's obvious. There's some kind of episode where your tissue was overloaded and damaged. Examples may be a sprain, a strain, a broken bone, dislocation, some kind of wound, a disc injury, things like that. Where your micro traumas are often called overuse injuries, but they don't have to be overuse injuries. But these are more like insidious, frequent, chronic types of things that sneak up on you. And they all cannot recover from just rest. Sometimes these are going to require further medical intervention, as well as macro traumas. But a lot of people just think, oh, micro trauma is not that severe, so it'll just heal with rest, which is not always the case. So again, some of those macro trauma injury types, I just wanted to make sure you know what those are. When I say disc injuries, I'm talking about the discs in your spine between your vertebrae. They could become herniated or bulge. Either one of those can lead to pressure on the spinal cord or one of the nerves that's leaving the spinal cord. Obviously, you guys probably know what the rest of these are. Dislocation, where two bones come together, they're forced out of that position, which can lead to damage to the ligaments, tendons, and muscles around that. Broken bone or fracture, that's self-explanatory. A sprain is a tear to a ligament, and a strain is a tear to either a muscle or tendon. And so if you have a strain, the exercise guidelines are going to say, basically, once the doctor has said, okay, it's safe for you to start exercising again, they essentially just want you to avoid using muscles that rely on that muscle or that tendon while it continues to heal. Microtrauma injury examples may include things like degenerative disc disease, where the discs between the spine begin to deteriorate. They may kind of flatten out. They can get almost like mummified-ish. They can, they basically they deteriorate. We have osteoarthritis, which is regular arthritis, just due to wear and tear on bones. You have osteoporosis, which is weakening of the bones. And you can have muscle imbalances where maybe one side of your body is way stronger than the other, one side is tighter than the other, or even skeletal malalignments where certain bones are not the same size, or they're not, they don't function as, one functions better than the other, or even a crooked spine, things like that, that may affect things when you exercise. What causes these things? Mostly it's going to be either training errors or inappropriate or poor program design, progression, rest, recovery, training services, equipment, technique, flexibility, motor control. And again, that skeletal malalignment, where if you don't have a healthy alignment or muscle balance as you exercise, you can continue to kind of exacerbate those types of micro traumas. All right, so it is generally agreed upon that tissue follows a pattern of healing that includes 3 phases. So they want to make sure that you know these 3 phases so that when you are training a client, you know what phase of healing they're in. And before you give them a new exercise, you know what that body part can tolerate so that you don't impede the healing process or cause additional injury. So we have first inflammation, then repair, then remodeling. This is just a little figure from your book that kind of explains it really well. Usually immediately 0 to 5 days, we start with inflammation. 5 to 7 days, it moves on to proliferation and repair. And then, and it's not exact, but around 21 days, we may have remodeling up to a year, right? So there's an outcome for each one of these little periods here. And the outcome for the first one is we want that injury to become stabilized and contained, any debris is removed. And that happens, due to your own body. Your body will do that part, right? That's what inflammation is. So the outcome for the next stage, angiogenesis. Genesis means to like new creation. So we want to create new everything, fibroblasts, all tissue, everything that we can repair and regenerate. That's what's trying to happen there. And then the remodeling is the formation of actual collagen. And hopefully this time we're starting to reduce, scar tissue the best that we can. So the inflammatory phases just go a little deeper. It's your body's initial reaction to an injury, and it's necessary and normal for healing. And basically, just after an injury, things are released into your bloodstream. And these things increase blood flow, they increase capillary permeability. So things can get in and out of the capillaries more easily. It's going to cause edema, which is swelling. And all of these things are going to inhibit contractile tissue function, right? They're going to inhibit your muscle's ability to contract. And then these substances may kind of noxiously, meaning kind of cause pain, stimulate sensory nerve fibers, causing pain that may contribute to decreased function. So there are things that actually cause your contractile tissue to decrease, and then there's pain associated with it. So most people don't like to move an injured body part. And although it is critical for healing, if it does not end within a reasonable amount of time, further healing may not occur. So again, this is the most important time to seek medical intervention, or at least get an opinion to see what an injury really is. I talk about it a lot in my first aid class, but people tend to ignore injuries and think, well, I'm just going to give it a few days and see what happens, or I'm going to give it a week. It could be something not very severe and it might go away, but you really never know. So it's kind of better to be safe than sorry. I do understand that money is an issue when it goes to seeing a doctor. Then we move on to the repair phase. And again, the inflammatory phase may actually continue on through this repair phase, but here's where tissue begins to repair, anywhere from 3 to 5 to 7 days after the injury. And it could even last a few weeks to a few months. It allows for the replacement of tissues that are not viable after injury or even surgery. So the tissues that can no longer function, they're going to die, they can't regenerate. It's going to replace it with new tissue. So in an attempt to improve tissue integrity, the damaged tissue is regenerated. And in place, new stuff will be created, which a lot of it's going to be scar tissue. The goal during this phase is to prevent excessive muscle atrophy, to promote collagen synthesis. Remember, collagen is a lot of the stuff that your tendons and ligaments are made up of. It provides structure and strength and to your muscles and ligaments and things like that. We also wanted to avoid disruption of these newly formed collagen fibers. Then we move on to the remodeling phase, where the weakened tissue produced during repair is strengthened. So when you first start to repair, you're creating new tissue, but that tissue is not necessarily fully functioning or as strong as it's going to get. So during the remodeling phase, then we take that new tissue, we strengthen it, and then basically, even though these collagen fibers will improve the strength of them, it is unlikely that they will ever be as strong as the tissue it's replaced, which sucks in a way because a lot of people are like, well, I'll never be the same again after an injury. And although it may be true to say most collagen fibers may never be as strong, it doesn't mean you still can't get back to, a competitive level or doing the things that you used to do. You just, if you want to get to that point, you and or your client has to make sure that they're following every protocol to allow this injury to heal the best it can. So clients will improve function by continuing the exercises performed during the repair phase, and then by adding more advanced activity-specific exercises that allow progressive stresses to be applied to that injury, right? So we want to progressively add more and more stress to the injured area in a way that we know it can support that load. So some of the key points here is that rest maximizes the natural physiological processes of the inflammatory phase, and it supports appropriate tissue healing. So rest, rest, rest. Full restoration of tissue function after an injury can be optimized through careful alignment of activities with the physiological phase of tissue healing. So knowing these phases can really help you decide what you're going to be doing with this client in order to minimize further injury and increase healing. So there's a couple charts in your book, but this one just kind of goes across. It talks about now we have these 3 phases, and it's talking about what you can kind of do during these phases. So during that first inflammatory phase, we really want to, do you guys remember RICE from first aid and CPR? And now they've added a P for price, so we can control pain, inflammation, rest it, ice it, elevate it. Compression, that is a little controversial. Compression means wrap it with something. I would say allow their physician to decide, but some authority, I don't know, references will say do not compress it, while others will say add compression. Because if I sprain my ankle and I wrap it up with an ACE wrap, that compression will actually provide support. It will decrease blood flow and swelling. Although if it is a more severe injury that I'm not aware of, it could actually cause more harm. So that's the controversy on compression. But RICE or price now is what you want to do in this phase. Cold, not heat. A lot of people think it's cold or heat. It is not heat. All right, and then when you're moving on to the repair phase, you want to do like range of motion things, flexibility, balance, proprioception, neuromuscular control, and then strengthening. And then once we get to that third remodeling phase, we really want to continue to focus on what we've started here and then start moving to functional strengthening. So strengthening is just, let's get these muscles strong. We're not doing a lot of, plyometric or dangerous or functional things that we're just doing pure, safe strength things. And then we're going to move on to more functional strengthening so that we can now eventually return to pre-injury activity. You just need to make sure you know these terms. An indication is an activity that will benefit an injured area of the body or a specific population. An indication, something you want that client to do. A contraindication is something you do not want them to do. It is something that is inadvisable or prohibited. Prohibited as in like, don't do this or you're going to continue to hurt yourself. And a precaution is something that can be performed as long as it's under supervision by someone who's qualified and the client is doing it safely. They're monitoring their limitations and they're monitoring their symptoms as well. Hang on, my mouse disappears sometimes. Okay, and so now this part of the rest of the chapter, it just goes into specific injuries. And they really talk about the major joints of the body that we really want to, focus more on with personal training. So the first one's low back. A lot of people have low back pain. Low back pain is a catch-all term involving several different things, but it could be a bunch of things. Disc dysfunction, muscle strain, stenosis, right? That's narrowing of the spaces in the spine, resulting in something, compressing on your nerve. Spondylosis and spondylolisthesis. It can be a lot of things. Each one of those is a different issue and it may require different treatment, but you can kind of logically treat them all in a similar way where you are promoting and reinforcing pain reducing postures and movements. So if your client, it doesn't matter if they have this, or this, what I'm doing is promoting and reinforcing postures, movements, and exercises that will help reduce that pain, not increase it. And then avoid any movement that causes pain, that to increase pain or that causes that pain to radiate or spread over a larger area. So regardless of what they have, these are 2 things you can do for all of those. Low back pain can be acute, subacute, chronic. It can be caused by a lot of different things. Sprain, strain, herniation, osteoarthritis, tight muscles, hypo, meaning too little mobility, hyper, too much mobility, sacroiliac dysfunction. These are just some of the things. In any case, there are often similar contributing factors associated with low pain. Like, so there's similar things that kind of apply to all of these. So in general, low back pain responds well to spinal stabilization exercises. That's something you're going to want to kind of look into if you have a client with low back pain. Also, posture corrections, making sure they're working on posture and flexibility. And not just flexibility in the way that they've been doing, making sure that they're actually practicing flexibility where they are lengthening tight muscles, right? If they have muscle imbalances, that may be an issue as well. So the common culprits here are going to be either poor tightness or poor posture in the hip, like the hip flexors, your lateral rotators, which are generally your glutes and your hamstrings. So your hip flexors, your glutes, and your hamstrings are often tight. So you really want to work on this with these kinds of clients. The extensors of your low back and your abdominal muscles are essential for stability and support. So you're also going to need to be strengthening your low extensor muscles and your abdominal muscles. People with low back pain should have a balance, should have balance work also put into that program. Okay, so now we're going to kind of start moving on to really more specific areas. And so they start talking about a lumbar disc injury, but I just real quick wanted to show you an illustration of discs between your vertebrae. So here's your spine, here are your vertebrae, and this just happens to be a lumbar area. So the person is looking this way, right? So this would be like what a normal disc, and obviously this is not a picture, it's an illustration, but a normal healthy disc between two vertebrae. This disc is a fibrous, capsule that keeps these two vertebrae from rubbing on each other and things like that. So then you could start having things like degenerative discs, and that is what I had in my cervical spine, and I've had to have two of them removed, two separate surgeries, because I had degenerative disc disease, meaning the disc just it starts to kind of like just deteriorate, and they basically say it almost becomes like mummified. And what happened to me though was when it did that, it stuck out and it started to push on my nerves and spinal cord, causing paralysis of my right arm and pain and tingling and all sorts of things. You can also have a bulging disc, and that is just where the disc starts to kind of bulge out between two vertebrae. And again, same thing, it can start to push on the spinal cord or nerves. And then you could have a herniated disc. So the disc itself has an outer layer, and I'm going to show you in a minute, and then it has an inner layer. A herniated disc is where the inner layer kind of squirts out. It's like this jelly-like stuff. And so again, that can press on your spinal cord and nerves. So all three of these things can end up leading to the same symptoms or the same type of pain, but it's due to three different things where they push on the spinal cord and nerve. And then you could also just have thinning discs. Generally, as you age, that's going to happen. Or discs that start to form kind of like arthritis and sometimes bone spurs and things like that. Okay, so here is what, if you're looking down, then I cut you in half and I'm looking down on your spinal cord. So here is a vertebrae, here's your spinal cord, here's the nerves leaving your spinal cord, and then here's your disc. So the outside of the disc, they call the disc annulus, and the inside, they call it the nucleus pulposus. And so when you have a herniated disc, this nucleus pulposus kind of just almost like a jelly donut squeezes out and then begins to push on the nerve of the spinal cord. That's what a herniated disc is. The problem with anything poking into a nerve or spinal cord is that it could create permanent damage. A lot of times, once you take the pressure off, the nerve will heal, but not always. And so that's why it's kind of important to really make sure that if you have some kind of spine pain, that you really watch it and get it taken care of, or encourage your clients to. So if you know somebody has a herniated disc, particularly the lumbar The lumbar, the lower area of your back is going to be most common. I just happen to have cervical issues, which is probably the next most common. But mostly you're going to have a lot of clients with this low back pain. And so they may have low herniated discs. And so what you want to avoid is lumbar flexion, right? And favor extension. And that's because you want to prevent the posterior protrusion of the disc, right? You want to avoid posterior protrusion of this disc. So you don't want it to go this way. So what happens if you bend forward, it's going to continue, right, to push that disc that way. So that's why they say don't do flexion where you're bending forward. You can favor extension where you're leaning back, and then the disc kind of gets pushed more in this direction, which will reduce the pain. So contraindications would be things that include lumbar flexion, full sit-ups. You can still do things like squat, row, but you really need to be careful. So that's a precaution. Sit-ups are a contraindication. And then aerobic exercise precautions, you can do things like bike riding. But because of the increased flexion with leaning forward, it might be better to use like a rowing ergometer or things like that. Spondylosis and spondylolisthesis, these are essentially, I'm going to show you a picture in a minute. They're very related. So spondylosis is a defect or fracture in a part of your vertebrae in the lumbar area. And I'll show you pictures so you can think about that. And then spondylolisthesis is like this getting worse, and then possibly one of your vertebrae slipping up and over another. And so if you have a client with one of these, you want to focus on strengthening the muscles around that spine and avoid exercises involving lumbar extension. So this is different than a herniated disc. All right, so this is just a regular part of your vertebrae, this pars articularis. What happens in spondylosis is that there's a fracture in that area of your vertebrae. And after that area is fractured, what can happen is these discs can actually kind of slip forward, right? And so now the entire lower spine is not really supporting. So essentially your vertebrae are sliding down. And so that's what these two things are. And spondylitis, itis just means inflammation. So that's where I'm starting to have inflammation around here. This is the beginning. Sometimes this is the next, and then we come here. So you do not want to do lumbar extension where you're leaning back, because we obviously have some issues here. So key point, effective assessment for posture and movement impairments is essential for establishing appropriate, pain-free, low back and pelvis stabilization and flexibility exercises. All right, we're going to move on to the shoulder. Obviously, your shoulder is super dynamic. It moves in all sorts of ways, but because of that, we know that it is a little bit more at risk, right? So we have a lot of mobility, but we are susceptible to injury, and that can be acute, traumatic, atraumatic, chronic, overuse, things like that. I just real quick wanted to go through those muscles. So if you're just looking at the muscles of the back here on a superficial level, you're not going to see your deeper shoulder muscles. You're going to see your traps, right? You're going to see your lats, and you're going to see your deltoids. And you can kind of peek in there and see a little bit, but let's go deeper. Let's take off this top layer and let's just look at your rotator cuff muscles. And so here are your rotator cuff muscles. Here are your rhomboids, right? Here's your levator scapulae, and this is your scapula. Okay, so your scapula has muscles that surround it. They're all over it, and it has four main muscles that work together to create your rotator cuff. Now there is a fifth one down here, and this is your teres major, but it does come off the scapula, but it does not attach up here with the rest. It attaches to the front of your humerus bone, so it's not part of the group, right? The rest of them all come and attach right here. So I wanted to kind of give you a more clear picture of these muscles. And so your rotator cuff muscles, your scapula has the spine. So the muscle on top is your supraspinatus. This muscle underneath the spine is the infraspinatus. And then you have the teres minor, okay, that attaches with these guys. And then you have the teres major, and it originates from the same area, but then it attaches to the front of the arm. So this figure just kind of shows how all of these muscles come together and they attach here, while the teres major attaches elsewhere. And the point of your rotator cuff muscles are essentially to keep the shoulder stable and allow it to rotate safely. Okay, so shoulder and rotator cuff activation exercises. Your book goes through a series of slides that show you some of these. I also, if you click this figure, there's a video from YouTube that I kind of liked. So again, looking at your rotator cuff muscles, you have your supraspinatus, infraspinatus. Here's my teres minor. They took off major because it's not part of the group. But if I were to turn this around and look at the front of my scapula, I also have another muscle here, and that's my subscapularis. And those are the 4 rotator cuff muscles. So some of the exercises they suggest for rotator cuff exercises are external rotation, lateral rotation. You can do this laying down like that. Shoulder extension exercises. Transverse or horizontal abduction or extension, same thing. Lateral or external rotation. And then this is called the empty can, and it's kind of hard to see what she's doing, so I included a video. There's actually kind of a lot of controversy over this one now, so I would kind of do your own research on this and definitely ask your clients, PT, your doctor, if they want to be doing the empty can. All right, moving on to a new injury, subacromial impingement syndrome. I'm going to show you a picture, but subacromial impingement syndrome is pinching of that supraspinatus muscle, or the subacromial bursa underneath that acromial arch. And basically impingement kind of means it's squeezing it, it's squishing it. It does have a lot of contributing factors, but some are changeable with conservative treatment and others will require surgery. So let's look. Here's my clavicle, and here's this subacromial area we're talking about here. So here's a bursa, and that could be being squeezed, which may cause that pain. Or right here, my supraspinatus can also be being kind of pushed on and squeezed here. And so they kind of show you, like, with an illustration. I can have impingement system where it's pushing in it. I can have tears where it's starting to tear, or just overuse injuries where it's inflamed. And then I just wanted to throw this up there that a labrum, a lot of people are confused with the labrum tear, but that's just cartilage found in the shoulder joint. And so you can also have labrum tears as well. It's technically not a muscle, the rotator cuff, but this is just the area we're talking about. So I wanted to throw that in there. The most common type of labral tear is called the slap tear, just so you know, or sometimes they call it a slap lesion. If you hear that, it's basically just a shoulder labral tear. So what are you going to do if you have someone with these types of issues? You do want to continue rotator cuff and scapular exercises, multiple types of rowing, targeting rhomboids, middle and lower traps, focusing on scapular retraction and depression are all recommended. Overhead presses such as shoulder press or bench, upright row should be used very cautiously. Overhead pressing, all forms of bench press and the upright row should be used cautiously. And things like lat pull down in front of face or eccentric overload exercises should be used very precautiously. Another thing that you may have is glenohumeral joint instability. So the head of your humerus, the very top of your upper arm bone, can move too far forward, resulting in injury Subluxation, which means a partial dislocation or a full dislocation. And so some things that you can do are, again, rotator cuff activation exercises and making sure that your movements involve greater than 90 degrees of elevation while placing the hands, sorry, that any movements that involve greater than 90 degrees of elevation, particularly where the hands and arms are behind the plane of the shoulder, these are all dangerous because they can place the shoulder in an unstable position. And so they kind of have a criteria for shoulder exercises that are in a safe zone. And so that safe zone is below 90 degrees of elevation and elevation of the shoulder and anterior to the frontal plane of the body. So here's a picture. Safe zone. I don't want to be going higher than this. If I have that, if I have glenohumeral, like the top of your shoulder, the top of your humerus, joint instability, I only want to go up to here, 90 degrees, and I want to go from here to here. I don't want to go back because that's going to force that bone forward. And I only want to go to 90 degrees. So those are the safe zone exercises. People may end up getting rotator cuff repair. That's usually when you have damage to your rotator cuff tendons. Most often the tendon that is injured is your supraspinatus, including a tear that is full thickness, meaning it's completely torn. It's not just frayed. It is a complete tear. It is in two separate pieces. Movements and exercise guidelines when they come back to exercising are going to be rotator cuff activation exercises. Remember, your book listed a lot of those, but I also linked a video to this just for some more ideas. Overhead lifting and exercises like push-ups and bench presses that place the shoulder in a position of stress can result in overload to that rotator cuff and should be avoided. All right, moving on to the ankle. The ankle sprain is one of the most common sport-related injuries, accounting for 10 to 28% of all athletic injuries. And they think probably because so many people get a lateral ankle sprain where you roll your ankle outward, that a lot of people just say, well, this happens all the time. I'm just going to self-treat it. So you may end up working with someone who comes in with an ankle sprain. And the reality is they need to actually be seen by a physician before you start exercising with them. And then the book just gives these little charts where, okay, here I have an ankle sprain. That's my diagnosis. The contraindications, movement contraindications. I do not want to do any inversion with weight bearing where I start to, rotate your foot in or lean your ankle outward. I don't want to do that. Exercise contraindications, anything requiring loaded or full weight bearing based on pain and mobility. So you have to kind of follow the client's responses. And then these are your exercise indications, things that you should be doing. Open chain range of motion exercises and strength activities until I can continue to put full weight on it. And then functional progression, neuromuscular activities like balance and proprioception as the client can tolerate it. Then we move on to the knee. Again, just like the shoulder, the knee is very susceptible to injuries because if it gets hit in one direction, a specific direction, it's going to get injured. They talk about three of these really common conditions: anterior knee pain, anterior cruciate ligament injury, I forgot if I'm saying that right, and then total knee arthroplasty. So anterior knee pain, often called patellofemoral pain syndrome. And so what that is your patella's here, right? And then your femur's here, and your patella lays in your femur, but you have cartilage in here. And so what happens is sometimes, you have inflammation or damage to this cartilage and you start having pain between the femur and the patella. So in that case, they may, just say that they have pain when they sit for a long time and walking up and down stairs. And the exercise guidelines would be quadricep muscles, strengthening them. Strengthening quads does improve the knee pain, and unilateral balance tasks targeting hips are essential. All right, then I want to look at the structure of the knee real quick because we're going to look at an ACL injury. So here's your patella, your kneecap. Here's your lower leg bone, your tibia, the big one, right? We have our quads up here. And so if you look at the knee, we have like two crisscross ligaments between the upper bone and the lower here. So that's my ACL, and you have one in the back, which is your PCL. So we have a lot of injuries to this ACL here. And then you have ligaments on the outside here. Oop. All right. So I have my lateral collateral ligament, and then I have my medial collateral ligament. And again, any of these can be injured. And then we have our meniscus here. And so right now we're looking at an ACL injury, but you've probably heard of some of these other injured areas before. So ACL injuries, exercise guidelines use both open and closed kinetic chain exercises. Remember, open means that the distal part of that extremity can move freely. So if I am on the ground, or if I am standing up and I am squatting, my legs are not open, they cannot move freely. My feet, that means that is a closed chain when I'm regarding my lower body. An open chain would be maybe like a crunch, where not that I'm working my lower body, but if I'm doing a crunch, my feet are not like stuck to the floor, right? They're not fixed. And so they can be moving, and that would be an open chain. Closed chain is where they're fixed. Sorry if I said that backwards. Anyway, and then plyometric training can be acceptable if it's done safely. And they also talk about total knee arthroplasty. That means they are surgically repairing that hip. Years of repetitive loading can result in that degeneration of that hip. The most common indication for knee replacement is advanced degenerative joint disease, or osteoarthritis. So if someone comes in with that, you want to make sure that you include cycling, swimming, aerobic endurance-based activities that minimize joint impact loading, like jumping, running, leg press, multi-direction hip strengthening, calf raises, knee flexion, and extension exercises using low resistance and high reps are recommended. You will, as a trainer, encounter much fewer hip injuries than you will for knee and shoulder. Knee and shoulder are going to be a lot more common. However, the hip can experience injury and may be poorly aligned with osteoarthritis, and pain is the result. Hip arthroscopy, now this is different. This is a surgical technique where they go in and they try to remove, like just junk in there, and then maybe repair a torn labrum. So some things that you could do is unilateral and bilateral balance and functional activities, focus on activation and strength of the glute medius, emphasize progressively more difficult skills that challenge the client in all planes of motion. And then a total hip arthroplasty. They'll do this. This is the treatment that they're going to do if drugs and physical therapy does not work. And so after a total hip arthroplasty, you want to avoid high impact activities and definitely consult with a surgeon about what kind of exercises they want that client to do. They also talk quickly about arthritis. You have generally two terms: osteoarthritis, which is normal wear and tear of your joints. And then you have rheumatoid, and that is more of like an inflammation disease, and it affects your joints, but also the connective tissue. So a lot of the joint areas will start to look malformed. So they give you movement contraindications. Don't do high impact activities with osteoarthritis. You don't really want to be doing running, snow skiing, jogging, plyometrics, because that is super high impact. Things that are indications are things like bicycle, stair stepper, elliptical, aquatic swimming. These are things that are going to reduce the impact on those joints. Rheumatoid arthritis. You want to avoid high impact cardiovascular exercise, neck flexibility or strengthening, if any of them have any history of neck instability, and then movements outside any safe zone they may have. So contraindications may be running, jogging, upper trap stretch, manually resisted neck strengthening, and then behind the neck shoulder press. So they tend to have a lot of issues with that neck. Indications: moderate intensity, aerobic endurance, stationary bike, elliptical, stair stepper. Work on range of motion and flexibility. Isometric exercises are good for those unstable joints. Water aerobics, bicycle, stationary, and then low resistance training are all good for this type of arthritis. So this is our last slide. In conclusion, you may work with a lot of people who have a lot of different issues, and you're just going to have to make sure that you review those injuries before you start working with clients. And it would be great if you can talk to their physical therapist and or at least get some kind of note from a doctor about what they do and do not want you doing. It's probably better to go not as hard, right? Modify, go low. It's better to start and you can work their way up. And when designing your programs with them, you want to make sure you understand that these basic types of injuries and the stages of healing. So that is chapter 21 in a nutshell. Let me know if you have any questions. Thanks, guys.